Thank you all for joining us today. My name is Stephanie Doback, and I'll be the moderator for today's webinar titled A Practical Guide to Blenderized Tube Feeds. I'm excited to introduce our speaker, Lisa Vardy. Lisa is a registered dietitian from Vancouver, Canada. She was born and raised in Vancouver and completed her degree at McGill University in Montreal. She has worked since 2011 in diverse inpatient and outpatient settings and has spent the last 6 years working at the ALS Center. The ALS Center services all those diagnosed with ALS and PLS in British Columbia and Yukon. During that time, she has focused her work on home enteral nutrition, particularly on home blenderized tube feeds. So you guys know the gist by now, but we'll have a Q&A at the end of the presentation. You can submit questions via the chat feature at any time during the presentation, and I'll relay them to Lisa during the Q&A time. Alternatively, you can raise your Zoom hand during Q&A time, and we will call on you to unmute yourself to ask your question. Attached in the chat is the CPE certificate. In order to claim CPE credit, we must have an evaluation. So at the end of our session, I will place a link to a 4-question evaluation in the chat box. And we ask that you please complete the evaluation so that we can have feedback to continually improve our educational offerings. Lastly, we always want to thank the ALS Association for providing the Quality of Care Program grant to support this presentation. And with that, I'll hand it over to Lisa.
Great, thank you. Thanks for having me today. I'm really excited to talk about Blenderized tube feeds. Blenderized tube feeds, particularly for ALS clients, is really where my passion lies, and I think it's really exciting that we're having more and more conversations about it these days. So Stephanie gave a little bit of an intro, but before I begin, I just want to take a little bit of time to introduce myself. So as you know, I'm a registered dietitian from Vancouver, BC in Canada, working with ALS clients in the center here. It services our whole province of BC. There's just one clinic here. And we also service the Yukon territories, which I don't know how familiar you are with this area, but it's just north of BC. And the ALS clinic was really where I found my passion for homemade tube feeds and supporting clients in the community with long-term tube feeds and providing them with the education and the tools to really be confident and to take ownership of their feeding system. So here in Canada, we like to take a moment before we start any meeting or webinar or presentation, and we like to recognize the land that we live and work on. As you know, it was not always called Vancouver. There were once the traditional territories of Indigenous people. So today I'm honored to be presenting from the traditional, historical, and unceded territories of the Coast Salish people of the Musqueam, Squamish, and Tsleil-Waututh nations. So you can see on the screen there, that's the beautiful city of Vancouver. For disclosures, I have presented a webinar in the past on home blenderized tube feeds for Nestle Health Sciences. So when a client is coming or considering blenderized tube feeds, it's the dietitian's responsibility really to provide them with all the information so that they can make an informed decision. As dietitians, we really rely on evidence-based practice recommendations to provide us with guidance to care for our patients. And it is within our dietitian's scope of practice to design and administer home blenderized tube feeds. That's like any product that is available for enteral nutrition. However, as some of you may have already come across, there really is little published professional standards for the use of blenderized tube feeds for tube feeding in adults. So what we have to do with, what do we do really with clients who come to us with this ask? Well, this was really the reality that I faced when I first started to work with clients with ALS. I hadn't really encountered that in the hospital setting. So I had to really be mindful of my own personal skills and competence in practicing blenderized tube feeds, and then take those necessary steps to ensure safe and competent practice. So for those reasons, I had to make myself an expert pretty quickly on the subject. And what came out of this deep dive into blenderized tube feeds were these practical recommendations based on weaker literature and mostly my personal experience working with clients on a regular basis who chose blenderized tube feeds as part of their care. So my hope for today is to pass on some of these tips to better equip you to feel more confident in recommending and guiding clients to use Blenderized tube feeds, as you see fit. So by the end of the presentation, learners will be able to present current evidence and practical guidance on Blenderized tube feeds. I'm going to refer to Blenderized tube feeds because it's a bit of a mouthful, so I'll refer to it as BTF for the rest of the presentation. List the advantages and disadvantages of BTF, and then describe the steps to initiate, prepare, and monitor BTF. So here's an outline of my presentation today. I'll try my best to keep to 45 minutes, so there's some questions at the end. We'll try and do the Q&A all at the end. If you feel that it really would be worth clarifying during the presentation, maybe pop it in the chat and I can clarify during the presentation, but otherwise we'll chat more at the end. So before we begin, I like to define BTF because I think different people have different definitions of it. So for me, Blenderized tube feeds are blended food and or fluids, really in any amount that's prepared in a home or hospital blender and administered through a feeding tube. So that includes fully homemade blends, commercially prepared formula mixed with food and fluid, or even just fluids on their own that aren't blended. So like a prune juice, for example. So this doesn't include commercially made BTF style formula where whole foods are blended together and packaged and sold commercially. And for clients, it's going to look different for everybody. Some of them will be fully on BTF, while others will do a combination of commercial formula and BTF, or even oral commercial BTF, any combination of that. So to give a little bit of a history on BTF, before the 1970s, blending food and liquids and putting it through a feeding tube was the most common form of enteral nutrition. However, after the introduction of commercially made formulas, homemade formula sort of fell out of favor, particularly as more and more options like specialized formulas became available. But like lots of trends, shifting back to a whole foods diet has become more popular in recent years. So that's why we're seeing BTF come back around. So I'd like to begin by discussing some of the advantages of BTF. So some potential advantages to making your own blends at home include tailoring the blends to accommodate diet restrictions. So that can include food allergies, medically necessary diets, as well as food and diet preferences, and culturally or religiously or even ethically appropriate foods. So this is also a benefit. There's also the benefit of including more food diversity, because we know with commercial formulas, you're getting the same ingredients over and over again. Something that I found particularly important with some ALS clients is that making blends at home can also provide an opportunity to be included in that social aspect of eating. So by providing a nurturing experience around meals and potentially sharing the same meal as those eating at the table with them. There is a potential for lower cost that really depends on the ingredients you choose and what formula you're comparing it to. And then there's also the potential for improved reflux, gagging, retching, bowel regularity, bowel adaptation, improved gut microbiome. So there's all those potentials for an improved GI outcomes. Now let's take a look at some of the potential disadvantages. As with anything homemade, there's variability of what you make. So the nutritional composition can vary from day to day. These blends may be difficult to make nutrient dense, and therefore they can be low in, they can be quite high in volume. With blending your own feeds, there also comes the extra prep time, which will either fall on the patient themselves or the family and caregivers. So those are important things to consider. Another big consideration is the decreased hang time and the potential for microbial contamination, as there's a lot more handling involved compared to commercial formulas, which you're just shaking up, opening, and pouring into a bag or into the syringe. For all of us on the line, there's an increase in clinician time. So the dietitian not only needs to educate themselves, but they need to teach the client and then monitor more compared to just a commercial blenderized tube feed. Another big thing is facilities may or may not support having blenderized tube feeds and may not have even the policies around it to support it. It's also important to consider that making your own blends may make it a bit more difficult to travel, especially long distance without a kitchen, maybe emergency situations where there's power outages. Those are all things that need to be considered depending on where a client lives and what their lifestyle is like. And then finally, there is the potential for tube occlusions that is found in literature as well as tube wear and tear. So there's lots of factors to consider when starting to think about BTF. And, I see why so many of us hesitate when a client asks about it. I know that I have had thoughts about limited published guidelines, my own lack of training and confidence that kind of ran through my mind over and over again when I first started working with patients on BTF. Firstly, like I mentioned, there's limited published guidelines, particularly in the adult population. And specifically, there were questions around the microbial contamination, the best viscosity for blends, the potential for tube occlusions, and the greater potential for nutritional inadequacy. And as a consequence of the lack of evidence, clinicians lack the formal training and then therefore the confidence to practice and teach BTF. And BTF is also a very involved process, and not all healthcare systems are set up to allow us for that time to learn and then teach these skills to our clients. So often it falls on the dietitian having a personal interest in BTF for it to be successful. So what do we do with all of these questions floating around? In my opinion, we have to work together as dietitians, doing the things that we're doing right now to filter through all the information we currently have and using our best judgment to provide our clients with all the information necessary for them to make informed decisions. So that's what I've tried to do over the years to formulate a bit of a decision tree to help guide my decisions and to help support my patients on whether BTF is right for them. And that decision tree is really what I'm going to be sharing with you throughout this presentation. Before initiating BTF, it's important to consider the patient's entire clinical picture and then compare the risks of the situation versus the benefit. That's to say that every patient situation is different, but here's what the evidence supports. Patients should be medically stable and ideally have a mature GI site with a tube size of a 14 French or greater. Did you know feeds are not encouraged in the literature because of the limited hang time and the implications associated with tube occlusion and difficulty replacing those J tubes? Smaller tube sizes are also a current concern for tube blockages. Some resources suggest patients should be stable on a bolus feed schedule before initiating a blenderized tube feed and to transition slowly, especially if that patient has not eaten by mouth in a long time. So those are the risks and benefits to analyze on the left-hand side of the screen. But on the right-hand side, you kind of have to zoom out and look at the larger picture. So even if a patient meets all the criteria that I mentioned, we still have to consider a few important factors. So what is the client's lifestyle like? What are their abilities or the abilities of their caregivers to prepare and administer BTF, not just for a day or for a week or for a month, but for long term? Do they have access to the necessary equipment or food storage? And do they have access to clinicians who can support and follow up with them on a regular basis? And also to keep in the back of your mind, this would go for any tube feed, is do they have access to emergency medical care should their tube get blocked and require replacement? And then a few last considerations that are particularly important for me to call out is that if you have a feed that requires a greater than a 2-hour hang time, there will be an increase in workload to refresh that bag every 2 hours. And if a patient requires fluid restrictions or they're volume intolerant, have impaired digestion requiring some specialized formula like elemental formula, or maybe they're on an ultra high protein diet, something like that, you may not be able to prepare a nutritionally adequate blend at home. And finally, for patients who are immunocompromised, there needs to be further discussions around the increased risk of foodborne illnesses and the potential for contamination of blends with extra handling before you proceed with the BTF. So you may have noticed there haven't been any specific suggestions so far about BTF within the ALS population. And that's really because these recommendations apply to all patient populations. In fact, in my experience, I've found over the years that ALS clients are generally an ideal population to go ahead with BTF, because more often than not, these clients are on the younger side. They're living freely in the community, and they have relatively little else going on medically. Again, that's a generalization, but that's a trend that I have noticed. Often their GI systems are functioning relatively normally. Maybe they have some constipation, reflux, but they're able to have a large size G-tube place, and they're able to tolerate bolus more often than not. And often the patients, the caregivers, the family are interested and willing to take the extra time and effort that's required for BTF. We know that ALS is a life-limiting disease, so I see a lot of caregivers in practice step up and really wanting to provide this type of care for their loved ones, or at least until the care needs become a greater priority. And then at that point, we just pivot the nutritional plan. So BTF is something we can explore, we can even follow for a while, and then as needs change, we pivot. So like I said, that's a generalization, but overall, I found this population a really wonderful group to work with for this type of nutrition intervention. Okay, now I'm going to get into the steps of how do we do this. So once you determine that a client is a good candidate for BTF and they're interested in pursuing this option, there's no set way to prescribe or teach a BTF. So I'll discuss how essentially I've created a practical guide to initiate and monitor a client on long-term tube feeds that's worked really well for me in practice. So I start off by calculating the macronutrients needs for the client. And initially, this is no different when estimating for commercial formula versus BTF. So you'd use your calculations that you normally would use for ALS or any other population. Either way, as you know, calculations are estimates. So if you have a client that's already on enteral nutrition, it's going well for them, just replace the commercial formula with BTF for 1-to-1 calorie replacement. And then you follow up closely after that. There's some research that suggests clients may need more calories from BTF versus commercial formula, but in practice, that's not always the case. And then we look at fluids. So it's important to optimize hydration before starting the transition to BTF to minimize the risk of dehydration and constipation. I find that the fluids often get forgotten about at the beginning because people are so focused on the nutrition piece and this new learning that sometimes they forget the fluid. And that can really interfere with assessing whether or not the patient is tolerating it. So once you've optimized hydration, you'll slowly transition over to the blended diet. So since we don't know how dense the patient's homemade feeds will be, what I suggest is starting with a minimum of 50 ml water flushes before and after feeds and before and after meds, and then calculate and adjust water flushes once a few blends have been made and we sort of know the volume of their blends, and they can be measured after they've done it for a few days or a week or even 2 weeks. So the reason that I say that is because once you calculate the client's fluid needs, you want to take the total feed volume, which, like I said, you don't know until you've made it a few times, and then you times that by 0.7 or 0.75. And then the additional free water is determined from the difference between those two numbers. So I don't know how clear I've made that, so I'm just going to give you a little example. A client needs 2,400 mils of water per day. Their feeds provide 2,600 mils of BTF in 24-hour periods. So I'm going to times the 2,600 milliliters by 0.75. That gives you 1,950 mils of free water. So you'll need an extra 450 mils of free water spread throughout the day. So you can put that before and after feeds, before and after meds, and then maybe water flushes in between, depending how much volume it is. And then you start, and then we monitor and adjust accordingly. So now that we've taken care of the macronutrient needs, we will need to make sure that the micronutrient needs are met. So I have noticed a trend that dietitians, myself included, kind of have a tendency to want to be highly calculated, but that's not realistic for clients who eat orally outside of a controlled environment like a hospital or care home. That's assuming that no food is brought in. But we can't really let that lack of control stop us from supporting clients who want to pursue this way of feeding. So with clients living at home with ALS, for example, we control what we can, and then we sort of have to be realistic and practical at the end of the day. So on this slide, I've called out a few important micronutrients that I found often get left out of homemade blends. But if your client is a picky eater, they're on a restricted diet, maybe they have other medical concerns, you may need to add other micronutrients in. But I find essential fatty acids are often missed. Sodium, interestingly, is often missed, and that's because people are making everything homemade. So we're often not getting those prepackaged items that are higher in sodium, or people are forgetting seasonings and table salt and pre-made sauces like barbecue sauce. So they tend to be on the lower side of sodium. And then vitamin D likely isn't sufficient, just in diets in general, especially if you live like where I live, where we're not getting enough from the sunshine. All right, so now we've taken care of initiation, and now it's time to prepare. So if you're transitioning from an oral diet to BTF or commercial tube feed formula to BTF, you want to take it slow. This is where you want to consider the individual client's previous food exposure, history of allergens, medical conditions. So if your patient is stable, the patient and caregiver are motivated, the standard is to transition by replacing one commercial feed with BTF per day, and then you increase every 1 to 4 days to the goal. You may want to incorporate one food at a time, or a slower or more individual transition. If the patient is nervous, or maybe they've had significant food intolerances in the past. And then you monitor. So clients may have temporary discomfort, gas, bloating. It shouldn't last longer than a few days, but those things should be monitored closely. And then again, ensure fluids are being met during this transition period to avoid dehydration and constipation. Okay, so now you have a plan, but what foods are you actually going to use? So there's a few methods to choose from in my experience. I tend to offer all 3 of the options listed, and then I guide the clients depending on what would work best for them. So the first one you can base on food groups. So this is my personal preference because it cues me to include a lot of variety in the diet. So I might use Canada's Food Guide. You may choose, to access Canada's Food Guide or My Plate, which is what the picture is here in the slide. And that can help guide you with the number of portions from different food groups that are required per day. The second option is to blend a family meal. So you create a balanced plate, just like everybody else at the dinner table, add it to the blender, add liquids as needed, and then you may need to consider increasing calories if it's appropriate. This one is hard to track calories, it's hard to track consistency, it's hard to track volume, but it is the least amount of prep work. And if you have other oral eaters in the house, it does help the client feel a little bit more a part of the meals. Something else to call out that I haven't mentioned yet is that I see a lot of ALS clients who will make their plate and then they will eat what they can orally, and whatever they don't finish, they may blend up and put through the tube. So that's another option. And then the last one is recipe templates. So recipes can be found in calories, or volumes might be listed, or even calorie density, like a formula, like a 1.2, 1.5, 2.0. There are recipe books out there. There's quite a few online resources. I know dietitians in my area have created one-off recipes in the past. And these recipes can be found in a 24-hour blend, meaning you blend all the nutrients that you need in one recipe for the day, and then it's divided into several feeds over 24 hours. There's also recipes per feed or per meal. And then there's also base recipes, which you can batch prepare and freeze, and then you take them out and defrost them, and then add daily additions to add variety to the diet. So once you've selected your foods, you have to consider the type of equipment available for your patient. I've run into this multiple times where I have a patient that's really interested in BTF, motivated, is cognitively aware, is able to do all the previous steps, but they don't have access to the appropriate equipment. So there isn't anything fancy necessarily about the equipment, but you do need either a high-grade blender or a regular or stick blender, and then a fine mesh sieve. And the types of foods and the volume of food you're blending may actually dictate what blender is best for you. So high-powered blender may not be necessary. You need the basic kitchen tools. And then you have to think about storage. So are you going to put it in those silicone cube freezer trays? Are you going to do it in mason jars, deli containers? Do they have an apartment-sized fridge and freezer, or do they have a deep chest freezer with lots of storage room? And then administration. So is a client going to be going home with a bolus, gravity, pump, combo? There's options and recommendations for all of these administration methods that I've sort of come across as being easier depending on what they choose. So for bolus feeds, are they going to use a syringe, or are they going to use a reusable pouch? Gravity bags, do they have access to purchasing large bore gravity bags? Because that will make the feeds run faster. Pumps, you have to look, if you're borrowing a pump, you have to look at the borrowing agreement, or if you purchase a pump, you'll have to look on the warranty to ensure that there's no restrictions with using foods other than commercial formula through the pump. If somebody has a low profile feeding tube, you may want to consider straight bolus extension sets versus a right angle. And then again, you have to see if that tube is large enough. I will point out that those catheter tip syringes are a 12 French. So although the recommendation is 14 French or larger tube size, the syringe themselves is smaller than a 14 French. So this table is something that I've created over time, lots of trial and error. We have a kitchen in the hospital that I work in where we've played around with different ingredients just to see how they'll blend. Patients report certain things to me as well. So this is sort of a table I've created over the years of foods that are easy to blend, and then foods just to use with caution. Again, everyone is different. They have different equipment, they have different skills, but essentially I've categorized foods into, easy and then not so easy. I'll give you a little story. I had one client who made all their own blenderized tube feeds. He lived on a large property and grew asparagus. Asparagus is kind of a stringy vegetable, but he blended it up and strained it no problem and had that asparagus through his tube every day. So anything is possible. Just depends how motivated you are to use certain foods. So I'll let you look through that in a little bit more detail, but generally speaking, grains should be cooked according to package directions or even overcooking so that they don't absorb liquid once it's added to the blender. Refined grains tend to gum up the blend, so refined grains like white pasta and white bread. Fruits and veggies, frozen, canned, fresh, those are all really good options. Like I said, stringier veggies might be harder to break down, but a high-powered blender might be the way to go with that. And then meat and alternatives, you want to look for moist, smooth options. It's easier for blending. Tough meats that tend to be harder to break down, and uncooked eggs, besides not necessarily being food safe, they can get all lumpy if they're not cooked properly. Milk and alternatives, most milk and alternatives are pretty easy to blend up. Harder cheeses are obviously are more difficult than, say, like a cottage cheese, but it's all fair game. Fats have really good density, like oils, butter, avocado, and potentially they have essential fatty acids. So it's an important category not to miss. You may notice that there are some foods that are also protein foods, for example. So you may have a dual purpose if you choose something like nuts or nut butter or fish, for example. And then we have the liquids. So the liquids need to be added to the blends to achieve appropriate consistency. I would just make a note that an oil is not really a good liquid for thinning. Oils have different purposes, and I'll talk a little bit more about that later. But you just want to pick a liquid depending on what your goal is. So maybe it's adding a higher sodium liquid like a broth, or maybe a calorie containing liquid if you need to make it more dense. Even something like a commercial formula like Boost or Ensure or something like that could be used as your liquid. And then I would, even though other is at the very bottom, it definitely has an important spot. Sweeteners, sauces, spices, they can provide extra calories, micronutrients, and then other non-nutritive ingredients or non-nutritive benefits like antioxidants, for example. And then if a client is making BTF on a regular basis, like daily or every other day, it may be important to consider some convenience foods as part of their recipes, just to keep them in the pantry or fridge or freezer for an extended period of time. So those are like soups, canned fruit, peanut butter, maybe even commercial blenderized tube feed formulas. General food safety principles are very important, especially if the patient is immunocompromised. I'm not going to dive too deeply into the subject, but a note to say that with any food preparation, hand washing is essential, and fruits and veggies, dried legumes, they should all be carefully cleaned and any soil removed. And dried legumes should be inspected, excuse me, for small pebbles prior to cooking. And then packaged items should be stored properly, and all foods should be used before their best before date. Okay, after all of that, we're finally ready to blend. So again, these recommendations are sort of pieced together. So there's a lot of variety in how you can blend, but I found this has worked best for my clients. So you get out your blender of choice. You prepare your foods by cutting them into chunks and placing them in a blender along with enough liquid to allow blending to a smooth consistency. A rule of thumb, just to sort of start out, is 1 cup of liquid to 1 cup of solids for a total of about 1.5 to 2 cups per meal. And then you can kind of adjust from there if the blend is too thin or too thick, but at least that gives you a good starting point. I do want to just point out that I have run into multiple clients who want to use like quote unquote healthy foods that are not always edible unless they're prepared a certain way. They may not be nutritionally appropriate. So I always remind patients that, for example, raw foods can be used, but they need to be foods that normally need to be cooked, like meat, rice, potatoes, should be cooked just as they would be if you were eating them by now. So you want to blend for 1 to 6 minutes to a consistency of about applesauce or thinner. And you may need to strain the blend to remove small chunks and seeds. If you're using pureed or liquid foods only, you may need to only blend it for 1 or 2 minutes. And then if you're using a thin liquid, you may not need to blend it at all. Like the example I gave before, if they want to use prune juice, there's no need to blend prune juice if that's all that's being added to the tube. So to dive in a little bit more into the textures of the blend, The appropriate thickness really depends on the size of the feeding tube and the administration method. So it can vary from slightly thick. So an ITSE, I have the ITSE in the top corner there. An ITSE 1 to a moderately thick, so an ITSE 3 for a pump, but it can be much thicker for a syringe or a reusable bolus bag. So for clients, ITSE's not exactly a great tool, I find, to just show them. So I find it's easier for them to visualize once they start to prepare their feeds for the first time. If I just tell them if they're doing pump or gravity, it should be drinkable like a drinkable yogurt. If the blend is too thick, it'll slow down or not run the feed properly through a pump, or could deliver inaccurate volumes. For pumps, at pumps and gravity, you want a drinkable yogurt if you're visualizing it. And then if you are going for a syringe, you can go a little bit thicker, like an applesauce. So basically, if you can pull it up through the syringe, you're good to go. It's also important to tell clients that using warm temperature foods can thin out a blend. So as well as if you freeze a blend, it can cause it to thicken up. So you may actually have to re-blend it before administering. It's also noteworthy just to kind of keep in the back of your mind that there's some evidence to suggest thicker feeds could reduce symptoms like aspiration, reflux, retching that's been found in the literature. So just to put that out there. And then in terms of storage and warming, homemade blends can remain at room temperature for up to 2 hours. That's why that recommendation about the G tubes is important, because if the hang time is longer than 2 hours, you're going to have to refresh that bag. So this recommendation exists not only due to food spoilage and increased risk of contamination, but also because the blends, if they're left in the feed bag for too long, the ingredients can separate out into layers, and then you increase your risk for clogging or inconsistent intake of nutrients. So if feeds are not used right away, they should be frozen within 24 hours. Otherwise, they can remain in the fridge and used within 48 hours. And once frozen, they're good for up to 2 months. I should mention that these guidelines are Canadian guidelines, and I have noticed looking through the literature, there is slightly different recommendations for the US, the UK, Australia. So take a look at your recommendations. And then warming up the blends, just to run the container under some hot water. Don't microwave, as it heats the food unevenly. And then plan for one-off days. That's really important. Even if you think your clients aren't going to go anywhere, it's good to have like a commercial BTF or a standard formula available. In an emergency, you want to plan that for that backup, because either maybe a power outage, you may need to leave the home in a hurry. It's always good to have a backup plan. And then the last step is monitoring. I'm going to try and run through these fairly quickly so I can give you a sample day, because I'm realizing what time it is. So to monitor their progress, this is sort of the biggest question. How do you monitor nutritional adequacy? I get that from dietitians all of the time. The way I see it, at the end of the day, if we do all the correct calculations for the nutritional needs, it's still an estimate. So first I look at what I can do easily. We can look for signs of adequate hydration, like urine output, skin turgor, dry mouth, as well as monitor weight, fast, muscle mass changes. We can look at nutrition-related labs if they're available. There are some standard suggestions of baseline blood work that can be done, every 3 to 12 months. You may have standards within your local community. And there may be a case for following more closely or looking at specific nutrients. But, I always have to ask myself, would I be looking at someone's blood work in this much detail if they were reporting the same dietary intake in oral form? Maybe yes, maybe no. Particularly palliative or end of life situations, often these patients would agree that fewer blood draws is better. In a different situation, the answer may be different. So it's really important to look at the whole picture. If you feel like it's necessary to look at the details of a client's intake, there are professional tools where you can plug in recipes or 24-hour recalls. and they can give you a snapshot at least of where the gaps may be. There's also free tools that are available. They look at sort of one nutrient at a time. Or you can rely on a more casual tool like food journaling or a 3-day food record. Again, the choice is yours and the choice of the clients. I know a lot of dietitians, when they're sort of dipping their toes into BTF, would prefer to get more information at first until they get more comfortable with blending and assessing patients long term, or even the client might be more comfortable with a closer look at things. And then we have to monitor a few things that I've called out. For GI symptoms, there's really no difference between investigating GI symptoms for commercially fed patients versus BTF. You really just want to investigate the cause before making any changes. So the biggest ones I see are constipation, diarrhea, bloating, and gas. I can chat a little bit more about that depending on where the questions are later on. Tube occlusions is another thing to monitor for. It can be caused by excess fiber, residue, seeds, nuts, lumps of food. However, in my experience, I've rarely seen this actually happen. Most often, the tubes get clogged because medications are inadequately flushed. But it is also important to note that medications can react with food, causing blockages. So flush, flush, flush. That's what I try and highlight. And then some tube wear and tear is normal. In our healthcare system in BC, we tend to leave tubes, even if they're looking a little worn, unless there's good reason for a change. Maybe the tube is cracked, leaking, there's mold causing resistance when you administer feeds or fluids or meds. I know that we're even more hesitant to replace a tube if they're palliative or end of life, if patients are not wanting to go through procedures that may not be necessary. I just try and teach clients good tube hygiene. So treat your tube well. You minimize contact time with oils because oils can degrade the tube, and flush the tube regularly before and after each feed. Clean it and the stoma site particularly once a day at least. And don't use any cleaning tools within the tube because it can scratch the inside of the tube, causing quicker bacteria to build up. And then a final note on foodborne illnesses. So while there's multiple studies that show BTF can contain bacterial contamination in comparison to commercial formula, there's really no clear data to show the effects of this contamination on patient outcomes. So it's important to look at the individual client and then determine if that risk is acceptable to them. Really what I do is I educate families on food safety, and then I emphasize the importance of preventing foodborne illnesses. And then for myself, I like to keep in mind when assessing a patient that you may misinterpret a foodborne illness as not tolerating the BTF. So that's really all we can do for that. Okay, I have a minute or two to show you a sample day of BTF, just to give you a little bit of a glimpse into how I like to do it with a lot of my clients. So after spending time trying all the different methods, I essentially menu plan for clients. So I came up with sample menus where the food group and number of portions have been broken up, and then examples of those foods were provided. I created them from 1,000 kcals going up by 200 kcals per day, up to, I think I made it to 2,800 kcals per day. And I give that worksheet to patients so that they can use it to select foods. So this is an example of a 2,000 kcal diet. And then you can see grains or starches, they need 6 portions a day. And I've chosen 1 cup of cooked quick oats, which is 2 portions, 1 cup of cooked rice, that's another 2 portions, 1 cup cooked quinoa, another 2 portions. And I've done this for all the different food groups. So we've got our grains and starches, our veggies, our fruit. On the next slide, we have our milk and alternatives, meat and alternatives, fats, and then liquids. And then I'll show you what a day looks like once you've picked out what you want for the day. If you were to blend it all together, that's totally fine. But if you wanted to blend it per feed, breakfast would look like oats made with soy milk, and a cup of coffee. I often see patients do coffee or tea through their tube. A cup of frozen and thawed mixed berries, and a tablespoon of peanut butter. Lunch is a cup of rice that was made with coconut milk, half a cup of spiced black beans, a teaspoon of flaxseed oil, with 1 cup of carrots, a cup of applesauce, a cup of cottage cheese, and some water or broth as needed to blend. Their snack was a cup of yogurt, a hard-boiled egg, and half an avocado with 1 cup of spinach, and then coconut milk or water as needed to blend. And then dinner is a cup of cooked quinoa made with broth, half a cup of frozen peas, a half a cup of canned corn, and a half can of drained tuna with a teaspoon of flaxseed oil, and then water, broth, or coconut milk as needed to blend. So you can see if you did it this way, the other oral eaters in your family could potentially be eating most of these items. Okay, that's it. I think just in the nick of time. So thank you very much for listening to all that. I know that was a lot of information, so hopefully we'll have a chance to answer a couple of questions for you.
Thanks, Lisa. That was amazing. And we have some
Okay.
questions in the chat, but also you can feel free to unmute yourself and ask the question.